So today we are going to discuss the Burns and ARDS uh, station from critical care. So 28-year-old man was caught into a house fire and burnt some portion of his body and was taken to A&E. On examination, she is tachycardic and hypotensive. Oxygen saturation is deteriorating. Chest x shows bilateral infiltrates. So calculate the surface area of the burn according to Vella's rule of 9 and Lund and Brohr chart and Palmer surface area, which is equal to 0.8%. 1 Palmer surface area is equal to 0.8%. So here you can say that like these are the methods which calculate the surface area burn. The burn surface area. How will you manage this patient? So I will manage this patient according to ATLS protocol in ABCDE manner. Airway, look for the sign of airway burns and inhalation injury, as it may cause airway edema. So consider intubation if there is airway edema, because it will later on this will be very difficult to intubate because there will be very much laryngeal edema. And breathing and ventilation, so ensure adequate ventilation and can be ensure that adequate ventilation can be achieved, as tracheal or pulmonary burns can impair effective gas exchange. Also full thickness chest burns can impede chest expansion. So in such cases, if there is a scar, you have to consider a sclerotomy. So circulation is too large bore cannula, and so too large bore cannula and fluid resuscitation. Any patient greater than 15% total body surface area. Any child greater than 10%. So you have to give fluid. Consider fluid resuscitation in any patient greater than 15% total body surface area and child greater than 10%. So burn resuscitation fluid rates and target urine output by burn type and age. So category of burn: flame or scalded burns, and then we have electric injuries. So electric injuries, all ages, 4 ml into linger rectate into weight into total body surface area involved until urine clears. So in all ages, this is the formula we will consider. So urine output should be 1 to 1.5 ml per kg per hour until urine clears. Then we have the flame or scalded burns. So in adults and older children greater than 14 years or equal to 14 years old, so we consider this formula: 2 ml ringer lactate into body weight into total body surface area, 0.5 ml per kg per hour, or 30 to 50 ml per hour. So children less than 14 years, so you have to put 3 ml into per kg body weight into total body surface area. 1 ml per kg per hour urine output is needed. And then we have the infants, and then we have the infants, and then we have the infants and young children less than 30 kg, and then we have the infants and younger children less than 30 kg. For them, we have 3 ml linger rectate body weight into total body surface area and a sugar containing solution at maintenance head. So this is very important. Sugar containing, for example, 5% dextrose. So the urine rate should be 1 ml per kg per hour. So fluid should be given using Parkland formula. This is Parkland formula basically, in like 4 ml into weight into total body surface area. 50% should be given in first 8 hours, and then remaining 50% should be given in the next 16 hours. And then we have the crystallites only should be given only Hartmann solution or ringer rectate solution, because if you give colloids will move into the third space, because in burns the capillaries are very permeable, and so they will sequester the fluids. So point to note, starting point of resuscitation is time of injury, when the injury occurs, and deduct fluids already given. So if you receive patients from somewhere and they have already given fluids and initial receiving point, like let's suppose they have given already like mm, 1 liter, so you have to calculate the total fluid, and then you have to subtract the 1 liter which was given earlier. So why not to give colloids in burn? I will not give colloid because the increased because in burns we have increased capillary permeability. So in the first 24 hours, so this is the same thing. This is the same thing I discussed earlier. Colloids will pass to the extravascular space, exert an narcotic effect, and cause paradoxical augmentation of the third space, interstitial space. I can consider fresh frozen plasma, albumin, platelets after 24 hours depending on the condition. So in the first 24 hours, you never ever give colloids, but after 24 hours, I can consider FFPs, fresh frozen plasma, albumin, platelets after 24 hours depending on the condition of the patient. So how do you assess the adequacy of the fluid therapy? A number of clinical parameters may be used. Clinical measures of the cardiac index, peripheral warmth, capillary fill time, and urine output, central venous pressure and its response to fluid challenges, core temperature such as the rectal temperature, and hematocrit, which determine the plasma volume, and the red cell mass. This is unreliable if there has been a recent transfusion or hemolysis. So you have to check the hematocrit. This can also give, if the hematocrit is low, so this can show that the plasma volume is high. There is dilution. What are the indication for the referral of a burn patient? So burn shock, which needs resuscitation, and hand, face, genitalia involvement, limbs involvement, face involvement, genitalia involvement. These are the indication for referral. Okay, and you have burn shock, which needs resuscitation. So deep, partial, or full thickness burn, superficial thickness or not, but deep, partial thickness are the indication. Significant edema, chemical burn. So these are the some indication. What is the best time to transfer the burn patient? So the best time to transfer the burn patient is after finishing first 8 hours of fluid replacement. So after finishing the first 8 hours of fluid replacement, so you should give the calculate the fluid, and you have to give half in the first 8 hours and half in the next 16 hours. So you can give the after finishing the first half 8 hours, then you can go for the you can refer the patient. So here what are the indication of intubation in a burn patient? So signs of airway obstruction, edema, hoarseness, stridor, excessive muscle movements, total body surface area 40 to 50% involved, extensive facial burns, burns inside the mouth, significant edema, difficulty swallowing, decreased level of consciousness, anticipated patient transfer with airway issues without qualified personnel. So you should intubate it prophylactically, or if the respiratory rate is greater than 35 breaths per minute, or if the saturation is getting below 65%, so you should go for intubation. Okay, so here we have the what are the signs of airway burns and inhalation injury? So hoarseness, stridor voice, burns sore around the mouth and nose, carbonated black sputum, and singed nasal hairs or facial swelling. What are you afraid of complication of burns? Burn shock. Hypovolemic shock due to plasma loss following loss of skin cover leads to hypertension, tachycardia, increased systemic vascular resistance, and a fall in the cardiac output. Sepsis can occur, ARDS, renal failure, due to microglobinuria, constricting circumferential burns, ischemic in limbs, ischemia in limbs, and ventilatory problems in the around the chest. So you should do a sclerotomy, electrolyte disturbance, hypo or hypernatremia, hyperkalemia, and hypocalcemia, coagulopathy due to disseminated intravascular coagulation and hypothermia, and hemolysis leading to hemoglobinuria and anemia. How to tell if the patient if he has superficial or deep burn? So partial thickness red, white, blistering sensate, full thickness white, leathery, and desensate. What to do if burn patient develops pyrexia? Investigate for sepsis, blood culture, wound swab, sepsis screen. So broad spectrum antibiotic until the result is available. Follow sepsis protocol, antipyretic agents. Sepsis protocol is give 3 to patient and take 3 from patient. So give patient fluids, antibiotics, and oxygen, high flow oxygen, and take from patient ABGs, culture, and ABGs, culture, blood culture, and urine culture. What are the classification according to depth of burn? So we have the superficial burns, which involves the epidermis. Here you can see, and then these are red, moist, and blanching occurs. Yes, heals normally. Superficial partial thickness, so epidermis, papillary, dermis. So basically we have this is the papillary dermis. It is like this. So this involves the epidermis and the papillary dermis. So this is dry, pale, blanching, yes, but heals normally. Deep partial, so it involves the super epidermis, papillary, plus the deep dermis. Epidermis plus the full papillary dermis and the deep dermis as well. So here mottled right appearance and no blanching. Surgical intervention needed, usually plastic surgery involvement. Needs superficial, partial split thickness skin draft. Full thickness, so we have the, okay, this is the 3rd degree, you can see deep partial thickness. Here we have the 4th degree, which is full thickness, and it involves the skin, subcutaneous tissue, so whole of the dermis, whole of the epidermis, and also involve the subcutaneous tissue, for example muscle, bones, and it is dry, leathery, and refer to burn center. Okay, so if according to degree, if you say, so here we have the 1st degree, and this is the 2nd degree, and here we have the 3rd degree. Sorry, the 1st degree, 2nd degree, it's mixed, mugged up. So here we have the, you can say, here we have the 1st degree, 2nd degree, 3rd degree, and this is the 4th degree. Okay, so superficial is painful, does not blister, does not scar from, does not result in scar formation, and the rest we have discussed already. Look at the X-ray. What are your differential? So it's ARDS or pulmonary edema or pneumonia. So what is ARDS? Acute respiratory failure, diffuse inflammatory form of lung injury. Okay, so we can discuss this in another video.